Good morning. Where's Professor Ben Yehuda? She had to leave because I wanted to give her the compliments back. What she said, I absolutely agree on what is needed to cure a CML patient. It's not needed to eradicate the last stem cell. Therefore, all our new treatment options, which we now develop together, are treatment options which help to increase the number of patients who achieve a deep molecular response and are able to discontinue treatment. But we know that all of them have residual stem cells. But these stem cells don't matter if you have a very low level of residual stem cells in the marrow. Therefore, this tolerance of these stem cells is important. And you have seen this long list of different targets of different drugs which have been proposed for the eradication of stem cells. But most of these studies which were done demonstrated that this approach is rather toxic and induces more side effects, and therefore the increase of the number of patients with deep molecular response eligible for discontinuation studies, I think, is much more important than eradication of everything. And one option is the new drug, which is ABL-001 or Asiminib, developed by Novartis. And the background for this new drug is that researchers have found a new binding site which regulates the activity of BCR-ABL, and when this binding site is blocked, it adds activity to the blocking of the ATP binding sites, which you all know from your drugs, from the conventional inhibitors like imatinib, nilotinib, dasatinib, ponatinib, and bosutinib. Yeah, this is a different site of the protein, and if you block this, it will inhibit BCR-ABL, and if you block the two together, it will even be more active and prevent resistance when you do it together. That means it's a background for combination therapy. These are some cartoons which illustrates what I meant. This is the normal ABL protein. Yeah, and this protein has a hole here. This is this binding site. And in this hole is a stick, like a lock. There is a stick. And this stick is part of the ABL protein. And this can regulate the activity of ABL. If ABL is needed in the cell, the stick is out. If ABL is not needed, the stick is in. The problem is, when you have not ABL, but BCR-ABL, you don't have the stick anymore. The stick is missing. And when the stick is missing, the molecule cannot be regulated. It's missing because you have the translocation of the BCR protein here, where the stick was. Here was a stick. Stick is deleted, but you have BCR here. Therefore, you cannot regulate this binding site anymore. And this is, of course, a perfect chance to do it with a drug. They introduced a drug which can now bind here because the stick is missing, and this is ABL-001. ABL-001 binds to this binding site, and now the whole protein, which is here, BCR-ABL, is inhibited. That's the background for ABL-001. And when you use this ABL-001 now, this cannot be seen here with the light, but you can overcome mutations which were induced in the other binding site. That means that's mutually exclusive. When you have a mutation in one binding site, you can use the other drug. When you have a mutation in the alternative binding site, you can use the other. Therefore, at the end, of course, that's a perfect chance for a combination treatment with a normal drug, which is regular Gleevec or imatinib, for instance, in addition this new drug Asiminib. And this was the intention of a phase 1 trial, where in a phase 1, of course, the most important factor is tolerability, how a new drug is tolerated. And Novartis did cohorts of patients with resistance, pre-existing resistance to tyrosine kinase inhibitors with different dosages of the drug. And then eventually they combined this Assiminib with the conventional drugs and found a good tolerability and a high rate of efficacy. But this is one study only. There, of course, you need further studies to demonstrate the advantage of such a combination over the regular treatment. So in this study here, you see that most of the patients, 65 here out of 100, had more than three or more prior tyrosine kinase inhibitors. That means they had Gleevec, dasatinib, nilotinib, and then this drug. That means there was no other chance at this time. A new drug was needed, therefore it was a good chance for these patients to receive a new inhibitor. And what happens, which side effects happened? Grade 3, 4 are the higher grades of side effects. And you see one concern of this new drug is, as with many other tyrosine kinase inhibitors, an increase of the lipase. Lipase is an enzyme of the pancreas, and it shows in some patients pancreatitis. This was not the case here. Only a few of these patients had a proper pancreatitis. Most had only a lab abnormality. But of course, that's a warning sign that we shouldn't use very high doses of these drugs because this may induce lipase increase. Therefore, they went back and are using now lower dosages which did not induce lipase increase. But in all dosages which were used, the drug was quite efficacious. You see here the complete cytogenetic response rate for the chronic phase patient, 75%. And this is MMR and log reductions. That means in a patient with a resistance to 3 previous inhibitors, these are quite good results. Of course, transplant should be considered as an alternative, but many patients were saved with this new drug now in the resistant situation. However, this may not be the end of the story. It's not only a salvage drug as an alternative for the other tyrosine kinase inhibitors. I mentioned in the beginning, we want to induce deep molecular response in more patients. Therefore, we may add ABL-001 to imatinib or to nilotinib or to dasatinib in the situation where a molecular response was achieved, but not a deep molecular response. Therefore, discontinuation is not possible. And we expect that when we add the drug here, we achieve a higher rate of a higher proportion of patients which achieve an actual deep molecular response and are eligible for discontinuation trials. And that's being done in a study which is the protocol, and I'm honest with that, is in discussion because not everybody agrees on this. These are patients here who are on imatinib and have no MR4 until 1%. That means the BCR-ABL level is between 0.01% to 1%. If you have such a situation and you are on imatinib and you go to your doctor and ask, oh, I want to achieve deep molecular response because I want to discontinue treatment, what is the answer? The answer could be, wait a year, it may happen in the next year, or you could change to an alternative inhibitor, which is imatinib or which is nilotinib or dasatinib, of course, or bosutinib. This could be done, of course. But here we have a randomization. That means it's, of course, as in all randomized studies, a play of chance. 1/4 of patients stays on imatinib. the other quarter switches to nilotinib, and half of the patients continue imatinib and get ABL01 in addition. That's a very difficult study to perform because of this 1/4 of patients who remains on imatinib. If you have the intention to change your treatment, you want to change, and you don't want to stay. And this will be discussed with the company next week in Barcelona, and Jura will participate in this discussion. And Jura, we hope together that we can change this protocol to help more patients to get a deep molecular remission. And the other trial, which is already ongoing, is a salvage trial. That means in third-line treatment. These are patients who had 2 prior tyrosine kinase inhibitors, and they are randomized to the new drug, Asiminiib or ABL01, and the comparator for this situation is bosutinib. And our criticism to this trial is that bosutinib is here given in 500 milligram, which is rather high, and we know that this induces diarrhea and liver toxicity. A lower dose is not in label, therefore the company is using the high dose here, but it may create some problems as well. But it's a good chance here, a 2-to-1 chance to receive the new drug, to have a benefit from the new treatment option in third-line treatment. But eventually, I expect personally that this drug is a very good first-line drug. It should be introduced into the first-line therapy because it inhibits BCR-ABL only, very specific. Yesterday, I talked about the so-called off-target inhibition. That means inhibition of other enzymes apart from BCR-ABL. And these create side effects. And a newly diagnosed CML patient doesn't need this inhibition. He needs inhibition of BCR-ABL. And this Asiminiib is an inhibitor for BCR-ABL only. Therefore, a combination of the traditional inhibitors and Asiminiib in addition after a few weeks added here to the treatment would be a good choice. We will start this study in Germany. It's a phase 2 study. We call it Fascination because it's first-line Asiminiib in combination, and we will start with that early next year. This is Asiminiib. The other drug, which is not new, but got a new chance now, is interferon. Interferon is toxic, as you know, the conventional interferon, but we have, of course, for a few years now, the pegylated interferon, the formulation, which can be given on a lower dose, which is much better tolerated and more efficacious. And many studies combined interferon with the tyrosine kinase inhibitor to induce a better response. This was shown in France, for instance. And I had a different idea, and we proposed in the German CML study group to induce a maintenance treatment with interferon to do what Dina Ben-Yehuda mentioned, to induce tolerance of the residual BCR-ABL positive cells to activate the immune system after a good treatment with a combination of nilotinib and interferon. This is 1 year interferon only after having achieved a major molecular response, and then eventually after MR4, 0.01%, we want to discontinue the treatment and want to see whether the induction of the immune system here creates more stability in the TFR period than nilotinib only. I don't want to go into the details with all the other drugs which were on the list from Dina Ben-Yehuda because these are not available now for you. What is available very soon is ABL01 and Asiminiib or any combination with interferon. These are very good choices for the next period of the treatment, and these choices will come into the standard of care very soon. I'm very sure with that. With the CML5 study, the Tiger study, we are here. If you expect results, you can see that most patients are still in the early phase. 250 patients are here in the maintenance phase, and 138 patients are in the discontinuation phase. And of course, I cannot answer the question whether this is better, one or the other is better, before we had all patients in this phase. Therefore, we have to wait the next 2 years until we get the early results of this study. But we use interferon already as a maintenance treatment. For instance, in the Enduro study in Germany, we randomize patients who are in deep molecular response to observation only and pegylated interferon. There is a new formulation here from a company in Austria, and we use this new pegylated interferon as a maintenance and stop then. That means we want to demonstrate that the activation of the immune system has an advantage. With that, I'd like to thank you for your attention and thank the German study group, which is depicted here at our last meeting for the cooperation. Thank you very much.